Hi everybody, welcome to this video on papillary thyroid carcinoma histology. It's going to be a very brief overview and I hope it helps you. Let's get right into it. So let's start with normal thyroid. So when we have thyroid, basically we're going to see a lot of follicles. They're going to be of varying sizes and they're going to contain this pinkish looking material called colloid. And then if we look at high power, we can see that there are follicular cells, which are cuboidal cells with round nuclei surrounding that colloid, so that compromises the structure of the follicle itself. And then once we get to PTC, essentially that architecture that we see here is completely lost and it's replaced by this papillary architecture. So you can see all these like fibrovascular cores, and that's kind of going to be more suspicious for some sort of carcinoma. Broad overview, when we think about nuclear features, that's very important for PTC. We're looking for that papillary architecture. So again, those finger-like projections. Nuclear features that are important are going to be the ground glass appearance of the nuclei, and nuclear grooves or coffee bean kind of appearance, or intranuclear pseudo-inclusions. And then we also have Sonoma bodies. So these are small calcified structures, often found within the tumor. So those are important to look for as well. Subtypes are going to be classic papillary carcinoma. So this is the most common subtype. And then this is the one that shows typical nuclear features and papillary architecture. There's a follicular variant, can mimic follicular adenoma, but often shows evidence of invasion. And then there is a tall cell variant. So you have these tall columnar tumor cells with abundant cytoplasm. There's a diffuse sclerosing variant, which shows extensive fibrosis and a desmoplastic reaction. And then in terms of differential diagnosis, other things to keep in mind include follicular adenoma. Those are going to typically lack nuclear atypia and invasion. Hurthle cell carcinoma. Those are going to have larger cells with abundant granular cytoplasm. And then medullary thyroid carcinoma is going to be a nest or sheets of cells with amyloid deposits. Amyloid is very important to keep in mind with medullary. So this is for a NIF tip, but I do think that it shows like the nuclear features of papillary thyroid carcinoma nicely. So you can see there's like a large size. You have your pseudo inclusions here, and then you have your grooves here, that coffee bean look right here. And then you can see central clearing, there's crowding of the cells, and they also have irregular contours. So these are all things to keep in mind when you're diagnosing the PTC. Tall cell variant, like we discussed before, carcinoma cells show a greater height than width, so it can be 3 times greater, just for reference. So you can see here, definitely very tall, very elongated versus short and plump. Follicular variant, of course, is going to have a follicular orientation. But if you look at the cells themselves, they're going to have like kind of prominent nucleoli, and then also you can see some grooves, and it doesn't look as like, neat and tidy as a normal follicle, which we saw in the first slide. And then diffuse sclerosing subtype, so there's just going to be a lot of sclerosis in between the cancer cells. And then in terms of molecular, very important, high yield BRAF mutation is going to be the most common, and that's very important to keep in mind. Also, you can see RET PTC rearrangements. That involves a RET proto-oncogene, and then you can see NRAS mutations. These are less common than BRAF, and they're also associated with an aggressive tumor behavior. Other genetic abnormalities, TERT promoter mutations, PIK3CA mutations, have also been identified, and there are more as well that have been identified too. IHC is also very important. So there are several markers that can be commonly used. So you can use thyroglobin, TTF1, and PAX8, and these are going to be general markers for thyroid follicular cell origin, and they're usually positive in PTC. So on cytology, you may see these being ordered. HbME1 is strongly expressed in PTC. Oftentimes, and it can be helpful in differentiating from benign lesions. Galactin-3 is another one. It can be overexpressed in PTC to help distinguish between malignant and benign thyroid lesions. CK19 positivity, diffuse positivity can support a diagnosis of PTC as well. Thank you so much for watching. I hope that this helps, and congratulations on leveling up again in terms of your knowledge base. If you have any questions, feel free to leave them below. I'm happy to answer them. Have a great day. Take care. Bye.